Okay, madam. Good evening, everyone. Welcome to another episode of Young Family Physicians Forum. Today, our speaker is Dr. Kaushaya Wickramaratne, a registrar from the Small Town Heroes batch. To tell a few words about Dr. Kaushaya, she had been an experienced physician working as MO-ETU, MO-endocrinology, MO-OPD in various hospitals, including DGH Mathara and Kamrupitiya. So without further ado, I invite Dr. Kaushaya to start her presentation. Over to you, Dr. Kaushaya.
Thank you, Dr. Hedika, for that kind introduction. Without much delay, I will proceed into the case presentation. Can you see my slides clearly?
Yes, we can see.
This was a patient which I met when I was doing my family medicine appointment at Base Hospital, Homagama. We'll say she's Mrs. S. She's a 74-year-old lady from Hokandara with a background of hypertension, diabetes for more than 10 years, and ischemic heart disease with 2 PCIs within last 5 years, presented with episodic vertigo for 2 months duration, which worsened within past 2 days. She claimed that she experienced vertigo. She used the word karakavilla, lasting for about an hour or 2. Worsening when she gets up from the bed and with head movements. In further questioning, there was no actual spinning sensation. She experienced unsteadiness within past 3 days, but still can walk steadily. I would ask what further information you need in the history with that short history. Can somebody tell me about the further information which you need in the history?
Any ear symptoms? Hearing?
Yes. What else?
Any aggravating factor, Kaushaya?
Yes. Like?
Head movement or getting up from sitting position.
Yes.
Like that.
Yes, exactly. And there was no hearing loss or fullness of the ear. There was no preceding upper respiratory tract infection. There was no respiratory symptoms. There was no chest pain or palpitations. She usually experienced constipation, but within last 2 days, she had 3 episodes of loose stools with several episodes of vomiting. She didn't have any postmenopausal bleeding, PR bleeding, or other bleeding manifestations. There was no urinary incontinence. There was no headache, no any focal neurological symptoms of note. Her past medical history and dark history. As I said previously, she's a non-patient with diabetes and hypertension for more than 10 years. And apart from that, she's having knee joint osteoarthritis. And she is on multiple drugs, including aspirin, clopid, enalapril, amlodipine, bisoprolol, nicorandil, and prazosin. And for her diabetes, she's on metformin and glycoside. And she has undergone 2 PCI, 2 LAG and RCA. And last echo showed ejection fraction was 50%. There was no valvular lesions. Conclusion was hypertensive heart disease. That's about her past medical history. And in surgical history, there were no significant surgical history. And in family history, she had a younger brother with hypertension and diabetes who had a stroke at the age of 64 years. She doesn't have any allergies to food or drugs. And she menopaused at the age of 50, no postmenopausal bleeding. In her social background, she is a mother of 3 children, now living with her younger son. Husband passed away 8 years ago. According to her, she is having poor family support. She is experiencing great difficulties when doing her day-to-day activities because of this dizziness. She worries about falls when she is alone. I would ask, what are the possible causes for her presentation? She's having dizziness lasting for about 1 or 2 hours without any ear symptoms, especially associated with positions. Can you tell me possible causes for her presentation? Or possible causes for dizziness and vertigo?
Heart block or bradycardia?
Yes, arrhythmias. Yes,
Posterior hypotension.
yes,
Vestibular neuronitis.
yes. Acute vestibulopathies. Yes.
Vertebrobasal insufficiency.
Yes. That's one of the interesting things. I would go into the list of the causes. There are a huge list for dizziness and vertigo, but I picked up specific ones. Probability diagnosis for patients presenting with dizziness and vertigo. For my patient, it could be postural hypotension, could be simple faint, vasovagal faint, could be acute vestibulopathy, and it could be BPPV, and even could be motion sickness, post-head injury, cervical dysfunction or spondylosis leading to kinking of the vertebral arteries. Those are the probability diagnoses. And there are serious disorders not to be missed, like neoplasia and cerebrovascular disorders. Neoplasia, it could be a acoustic neuroma, posterior fossa tumor, or other brain tumors, primary or secondary could be, or even an intracerebral infection causing abscess. Unlikely to be in this patient because of the absence of the fever and the things, but it could be a differential. It could be included in the DT of a patient with dizziness. And as you said, vertebrobasilar insufficiency and brainstem infarctions like pica thrombosis. And Dr. Helicke said about the cardiac arrhythmias. It's one of the most important cause to exclude, and even could be myocardial infarction in the patient with diabetes without the chest pain, and could be aortic stenosis and other valvular defects. And here are some pitfalls, those often we missed. Could be earwax, otosclerosis, hyperventilation, and alcohol and other drugs, and co-micturition syncope or situational reflex syncopes, And could be vestibular migraine, could be Parkinson's disease. And again, I would go to Mrs. S. On general examination of Mrs. S, she walks into the consultation room with a stick for support. She is not pale. She had mild dehydration. There was no features of hypercholesterolemia, no ankle edema, but she has dry skin. Her mood was low. In systemic examination, cardiovascular system examination, her pulse rate was 88 beats per minute. It was regular, but low volume. Heart had dual rhythm, no murmurs. When we checked the blood pressure in supine position, it was 148/90. And standing blood pressure was 120/76. And the postural drop was more than 20 millimeters of mercury. And her respiratory examination was normal and no abnormality detected in abdominal examination. And ear examination also was normal. And when CNS examination, I checked it without a stick, without the stick. Her gait was normal and no nystagmus, Romberg sign negative, and no other cerebral signs. Cranial nerve examination was normal. And to summarize the case, by history, her symptoms more suggestive of pseudo-vertigo, not the true vertigo, mainly giddiness. She's a non-patient with diabetes for more than 10 years, undergone 2 PCIs, and on multiple drugs, including Prasosine. She had vomiting on previous couple of days, most probably due to food poisoning, and led her to mild dehydration and worsening of her symptoms. On examination, she has postural drop, maybe due to tonic failure, dehydration, or drug induced. And at the clinic, we did ECG and serum electrolyte was done, and both were normal. And full blood count was checked and hemoglobin was normal, and she had a fasting blood sugar and it was also normal. And because she's stable at the presentation, she was managed symptomatically with antiemetics and antacids and well hydrated with oral rehydration solution as outpatient. She didn't need admission at that time. Noted in her clinic book, presence of a caregiver in next visit is vital to discuss about the patient. She was reviewed after 5 days with her son, and she was much more improved symptomatically with rehydration. And she was referred to us by a peripheral unit, and she was referred back to her usual peripheral unit after reassuring and consult to the son and adjusting the drug doses and referred to review if symptoms persist. And then I'll move into the discussion. Dizziness and vertigo. Dizziness or vertigo. The term dizziness is generally used collectively to describe all types of equilibrium disorders. And we can classify it as vertigo and pseudo-vertigo for convenience. As we all know, vertigo, in true vertigo, it could be central or either peripheral. And there are tests to differentiate the peripheral vertigo and peripheral, central and peripheral vertigo, like Dix-Hallpike and Hint's test. And it is frequently discussed topic. So I would go into pseudo-vertigo, which my patient had. And it is, again, can be divided into giddiness or lightheadedness, or fainting or syncopal episodes, or disequilibrium. And in my patient, most probably her symptoms may be due to orthostatic hypotension. And the orthostatic hypotension defined as a sudden drop in blood pressure upon standing from a sitting or supine position. Clinically, this is diagnosed by a sustained reduction in systolic blood pressure of at least 20 millimeters of mercury or diastolic blood pressure of 10 millimeters of mercury within 3 minutes of standing after being supine for 5 minutes. That means we have to keep the patient in supine position in the bed for 5 minutes and ask him to stand and stay still for about another 3 minutes and recheck the vitals. Or it is defined as this blood pressure drop may be in 60-degree angle on the tilt table. And a word about a tilt table. Tilt table test is not freely available in Sri Lanka, but it's there are places. It is done in NHSL Colombo, electrophysiology unit, and it can be done in RCD hospitals in the private sector. Before tilt table test, we have to do the basic investigations before performing the tilt table test. There are contraindications to the tilt table test, maybe coma, febrile patients who's unable to sit, patient with severe anemia, or who had recent strokes. We exclude those patients. Prior to the procedure, patients should be well hydrated, and it's better if we can avoid food for about 1 hour or 2 and hold all the medications the night before procedure and in the morning to increase the sensitivity of the test. If the antihypertensives are suspected etiology, allow to take those medicine as usual. This is a diagrammatic representation of the tilt table, and the patient is in a supine position in the bed, and the bed is gradually tilted up to several angles, checking the blood pressure and the heart rate continuously, and monitoring for development of symptoms. It's cost about 2,600 per session in the RCD hospitals. This sudden drop in blood pressure is usually secondary to failure of autonomic reflex, could be volume depletion, or even adverse reaction to a medication. It will be a bedside test. That is a simple test. Could be simple diagnosis for doctors, but for the patient, orthostatic hypotension is very bad feeling and reduce the quality of life and increase the risk of falls because of the sudden blackouts, and increase the cardiovascular diseases, most probably due to the hypoperfusion of the myocardium in hypotensive diastole, and will lead to dementia and even depression and even death with frequent falls. Orthostatic hypotension, the etiology could be neurogenic or non-neurogenic, and can also be related to medications. When I want to discuss about the neurogenic orthostatic hypotension, it is characterized by autonomic instability, It could be secondary to neuropathic diseases or neurodegenerative diseases, or simply because of aging. We talk about neuropathic conditions. The most common entity we encounter is the diabetes. And there may be conditions where the cholinergic receptors destroyed by the autoantibodies. And there are familial dysautonomias like Shy-Drager syndrome. And neuropathic conditions could be associated with vitamin B12 deficiency, or could be associated with autoimmune conditions such as SLE and Sjogren's like conditions. And there are neuropathic conditions associated with amyloidosis, renal failure, rheumatological and paraneoplastic conditions that leads to neuropathy. And the other category is neurodegenerative diseases, like Parkinson's disease, dementia with Lewy bodies. These patients will have autonomic dysfunction. And there is an entity called multiple system atrophy and pure autonomic failures. And those are the conditions which caused by neurogenic orthostatic hypotension. Then I'll move on to the non-neurogenic orthostatic hypotension. This is most commonly due to volume depletion. It could be anemia, could be dehydration, even hemorrhages, or dehydration due to hyperglycemia. And there are instances, medications induce orthostatic hypotension. In cardiovascular diseases, aortic stenosis, hypertension itself can cause orthostatic hypotension. And atherosclerosis disease, heart failure, vascular stiffening conditions, or arrhythmias will lead to non-neurogenic orthostatic hypotension. Other causes could be adrenal insufficiency and physical deconditioning with aging. And alcohol is another risk factor for non-neurogenic orthostatic hypotension. Regarding the pathophysiology of orthostatic hypotension, normally immediately upon standing from a supine position, there is pooling of 300 milliliters to 800 milliliters of blood in the lower extremities. We all know. And this pooling will decrease the venous return to the heart, and it will cause decrease in cardiac output. Because of the reduced cardiac output, it will trigger the baroreceptor reflex and increase in sympathetic tone and the decrease in vagal tone. And it will raises the peripheral vascular resistance and subsequently increases the venous return and increase the cardiac output. So in a normal patient, that will limit the fall in blood pressure. But in patients with autonomic dysfunctions, they are unable to increase the venous return by the baroreceptor reflex because there are dysfunction in baroreceptor reflex. Symptoms are usually triggered by changes in posture, are resolved by lying down or sitting. Because of the pooling of the blood in lower extremities, they may have transient loss of consciousness or a fall. Patient may complain these symptoms first thing in the morning on getting up from the bed, along the course of the day as they change posture. The cardinal feature is the symptoms getting worse with the head postures and the movement of the body. Orthostatic hypertension occurs with an abnormal delayed response to shift in the body's fluid balance on standing, as I said. There are two types of responses with the baroreceptor reflexes. We say it as classic and delayed hypotension. Classic means it is within 3 minutes of standing, you feel the symptoms. Delayed, that is after 3 minutes. We usually talk about this classic orthostatic hypotension. There are no much research about delayed orthostatic hypotension, that is after 3 minutes. There are common symptoms that patients present with the orthostatic hypotension. They mainly complain about lightheadedness, that is feeling faint, and they may complain about the dizziness. Some patient may have even transient loss of consciousness and falls following hypotension. And there are less common or non-specific symptoms. They may have blurred vision, visual field defects, and their concentration ability is poor. And with the chronic disease, there may be cognitive slowing and generalized weakness and fatigue and shortness of breath. Sometimes they may complain about chest pain and backache and lower extremity pains. And they have a classic headache that is called coat hanger type headache. That mainly headache is occupied in the occipital area. Coat hanger like headache, that means occipital area and between the shoulders. When we are taking the history of the patient with orthostatic hypotension, we can ask about the nature of the symptoms and the onset in relation to postural changes, whether it's aggravating when they are getting up from the bed or in a sitting position to stand position, like that, and whether it is recurrent or is it a persistent feeling. And again, we have to inquire about the food intake, hydration of the patient, especially the older patients, and whether they have noticed any diurnal variability of the symptoms or whether there are any prolonged recumbency. And again, particularly if symptoms appear after starting a drug, they may complain these symptoms occur after starting a drug. So we have to inquire about the medications which she's on, especially vasodilators, diuretics, which cause volume depletion, and antidepressants sometimes cause orthostatic hypotension, and even antipsychotics, that is one of the drug class we missed, and the dopaminergic drugs. And I would briefly go through some autonomic failures and their causes and manifestations. There are primary causes and secondary causes. And secondary causes, we know basically diabetes, amyloidosis like conditions. And the primary causes, there are several entities, but these are very difficult to differentiate one by one with the only from the physical findings. As primary causes, there may be pure autonomic failures, autoimmune autonomic neuropathies, and entity called multiple system atrophy, and another entity that is postural orthostatic tachycardia syndrome, though it is mentioned under primary causes, and it is autonomic failure, but the difference is it does not cause postural hypotension. It's a kind of autonomic failure, but it not cause hypotension. And I'll move into the pure autonomic failure. This is a disorder of autonomic function that do not affect the central nervous system. That is the main difference of pure autonomic failure that not affect the central nervous system. This is caused by the pathophysiology is the deposition of alpha-synuclein protein within the autonomic nerves. That is a degenerative disease. So patients may get the symptoms slowly and those symptoms get worse. Sometimes this patient with pure autonomic failure may go into develop multiple system atrophy even. We should carefully question the patient about the CNS dysfunctions such as gait disturbances or spasticities to exclude the other autonomic failures and come to a conclusion. That is one differential factor. And in this group of patients, orthostatic hypotension is the most common complaint they present with. But there may be problems with urination, salivation, sweating, and defecation. These features are less common in pure autonomic failure than the other entities. This patient, male patients commonly present with failure of either erection or ejaculation. This could be a common physical manifestation. In pure autonomic failure, they may not have any sensory loss or neuropathic pain. When we examine the patient, with pure autonomic failure, there may be decreased sweating manifest as heat exercise intolerance, and patient may have warm or dry skin. Their eyes may be affected. There may be ptosis or features of Horner syndrome. They have the orthostatic hypotension as a main feature, and they don't have compensatory increase in heart rate with standing in most of the cases. And in the abdominal examination, there may be distended bladder with urine retention. Sometimes, if we do ultrasound scan, there may be residual volume of more than 100 millimeters of urine as a residual volume. The next entity is autoimmune autonomic neuropathy. As its name implies, it is autoimmune conditions. It typically presents as a subacute or chronic condition. The pathology, it says antibodies to ganglionic acetylcholine receptors are present in about 2/3 of all subacute cases and 1/3 of chronic cases. The main pathology is antibodies against ganglionic acetylcholine receptors. This could be associated with acute demyelinating polyneuropathy like Guillain-Barré syndrome, and even may be associated with chronic inflammatory demyelinating neuropathy. These patients may have somatic, sensory, and motor disturbances with these autonomic failures. So there are no major differences in these different entities, more or less similar. For autoimmune autonomic neuropathy, patients should be questioned especially regarding dry mouth or dry eyes. These Zika symptoms may be associated with ganglionic acetylcholine receptor autoantibodies. And other degenerative disease entities, multiple system atrophy, It is a progressive adult onset disorder characterized by combination of autonomic dysfunction, Parkinsonism, and ataxia. The patient may present as a Parkinson patient. MSA with prominent autonomic abnormalities is still sometimes referred to as Scheidegger syndrome. It's a familial condition. It's an old word, but still in literature, sometimes it's used Scheidegger syndrome. And there are two entities of multiple system atrophy. One entity is with prominent Parkinson features, and other entity with prominent cerebellar features. These degenerative changes occurs in basal ganglia, pons, cerebellum, substantia nigra, and the other higher functions in the brain, and present with various symptoms according to the affected brain part. And in these patients, we see the orthostatic hypotension as a common feature. Apart from that, they may present with again urinary incontinence or incomplete bladder empty. And for this patient, as I said, it's like Parkinsonism. They have bradykinesia, rigidity, postural instability, tremors, and gait ataxia. The thing is, these features not responding to levodopa. That is where we can differentiate it from pure Parkinson. This is the entity which I called a deviation. It is autonomic failure, postural orthostatic tachycardia syndrome, we call as POTS. POTS is a common condition in especially in young female. It is relatively benign condition. It mainly affects only affect the sympathetic nervous system. POTS either develop slowly in adolescence or abruptly after febrile illness or other immunological challenge. The disease is characterized by excessive adrenergic symptoms when the patient stands up. Syncope may be occur, but it is unusual in this category of patients. They may have greater than 30 beats per minute increase in heart rate on standing. That means their parasympathetic part is little bit suppressed and their sympathetic part is overactive, and they may have tachycardia. There are hypotheses saying vitamin B12 deficiency in adolescents may cause sympathetic baroreceptor dysfunction in POTS. That's the vitamin B12 is involved in catecholamine synthesis. So there are hypotheses saying vitamin B12 deficiency in adolescents may cause reflex tachycardia in POTS. In this category, patients may complain different features like dizziness, blurring vision, like the other postural hypotensions, and weakness, lightheadedness, and fatigue upon standing. And they may experience palpitations and tremors and even anxiety. There are associated symptoms in POTS. Neurocognitive or sleep disorders. They may have exercise intolerance, dyspnea, nausea, abdominal pain, and sweating. And for a patient with orthostatic hypotension, there are no confirmatory tests as such. If we can do the tilt table test, it is a confirmatory test. But we can do the basic investigation to rule out other possible causes, like blood sugar levels, full blood count, ECG, and serum electrolyte. Those investigations we can do in the primary care level easily. And I'll move on to the management part. Management in orthostatic hypotension mainly depend on the symptomatic management and mainly non-pharmacological management that is much more important than pharmacological management. Non-pharmacological management, we can advise the patient to limit their physical activity, particularly in hot weathers. We know when the environmental heat is very high, there are patients who present with heat stroke, especially in elderly, because they can't sweat the heat out and they will present with shock. So we can ask the patient to limit their physical activity, and sponging with water during activity may help prevent overheating. And it has noticed that large meals may exacerbate hypotension because of the pooling of the blood around the splanchnic circulation. They would get postural hypotension. So we can ask the patient to take small meals, preventing this orthostatic hypotension, and perform positional changes. And when they are getting up from the bed in the morning, we can ask slowly raise the head from the bed and keep the legs swinging at the bed end, and swing the legs for a little, and then do some stretch exercises with foot and slowly get from the bed to reduce the orthostatic symptoms. And we can ask them to elevate the head end of the bed or keep the head a little bit up to avoid prolonged recumbency. And there is another measures that we should encourage exercise. It could be either climbing stairs or walking, or there are special exercises to minimize the symptoms of orthostatic hypertension, like leg crossing or squeezing the buttock muscles or abdominal muscles. The main aim is to avoid the venous pooling and pump the blood up. And they have recommend swimming for physically able patient to do swimming, and the hydrostatic pressure creating by the pools will gradually reduce the venous pooling, and gradually it will they will tolerate the autonomic dysfunctions. And we have to revise the drug history of the patient and discontinue any antihypertensive medications and other medications known to lower blood pressure if feasible, like prazosin. We can go for minimal dose if possible. Or we can review about the diuretics. And we can ask the patient to increase fluid intake and salt intake. We can ask them to keep a glass of water at the bedside when they are waking up in the morning. They can have a glass of water before getting down from the bed. They recommend tight support stockings, abdominal binders, that is tight fitting stockings which we use for varicose veins and things. And it's better if you can keep the stockings till about abdomen, but it is very uncomfortable to the patient. But if it is possible, it's good. And it can be supported with abdominal binders. And they have a test about anti-gravity suits for symptomatic hypotension, especially in very severe symptomatic patients with familial autonomic dysfunctions. They have used the anti-gravity suits, which can be inflated with inflated leggings, which reduce the pooling of the blood. That is especially, it is used in astronauts, but they have tried it in severe symptomatic patients. And if the patient is having urinary retention and or incontinence, we can do catheterization to relieve the symptoms. And sometimes the straining and vigorous coughing and those reflexes increase orthostatic hypotension. So it's better if you can reduce those instances, and we can, if the patient is having constipation, we can use laxatives, enemas to help bowel motility. So the aim is to reduce the straining. And though the non-pharmacological treatment is the mainstay of treatment, there are pharmacological treatment like hydrocortisone, midodrine, and pyridoxine. And these are, as you all know, hydrocortisone is aldosterone analog, and it will keep the fluids in the vascular compartment, reducing the symptoms. And midodrine is an alpha agonist, which will contract the vasculature and increase the venous return. And pyridoxine is an anti-acetylcholinesterase inhibitors, and it will stimulate the sympathetic action. And there are researchers with, they have given prednisolone for several months for patients suspected autoimmune conditions, and they have reported subjective improvement in those patients. But as primary care physicians, we can relieve the symptoms of the patient by non-pharmacological management without pharmacological treatment. And to summarize the things which I have told, it is essential to obtain orthostatic vital signs to diagnose orthostatic hypotension. This is an often missed simple test. Allow the patient to rest supine while obtaining the blood pressure and heart rate. We always should check the heart rate with blood pressure. After 5 minutes of lying supine, the patient should be asked to stand quietly for 3 minutes, and vital signs should be retaken. One can diagnose orthostatic hypotension if there is a 20 millimeters of mercury drop in systolic blood pressure or a 10 millimeters of mercury drop in diastolic blood pressure. And it is important to note fluctuations in heart rate when taking lying and supine blood pressure readings. That is because if orthostatic hypotension is observed and accompanying rise in heart rate of fewer than 15 beats per minute, that may indicate a neurogenic cause. And a rise in heart rate for more than 15 minutes per minute may indicate a non-neurogenic cause. It is not, there is no hard and fast rules, it's some clue. And when we are examining the patient, clinical examination should be tailored to identify features of relevant to symptoms and probable etiology. That means maybe there may be a murmur in a patient with palpitation. So they may indicate a structural abnormality of the heart. And if a patient is having slowness or movement or tremors, rigidity, those patients may have Parkinson's disease. And points to be noted. And NICE guidelines recommend checking for orthostatic hypotension in patients with hypertension alongside type 2 diabetes mellitus. They ask us to check the orthostatic hypotension in patients with hypertension alongside type 2 diabetes mellitus. And in those who have hypertension and are 80 years of age and over. That is the geriatric population. We have to check for postural hypotension in patient with hypertension. The American Diabetes Association advises assessing orthostatic hypertension during an initial assessment of hypertension in all patients having diabetes. And not only the initial assessment, periodically at follow-up, even when there are no symptoms. Those are the things I have to highlight in my case presentation. And as primary care physicians, we can help diagnose the conditions and advise lifestyle modifications. The goal of treatment is to avoid falls and other complications in the community. And the lifestyle changes will be the first line option for treatment. But there are pharmacological options available. And that's the end of my presentation. And if you have any queries, can ask.
Dr. Kaushaya, thank you very much for your very elaborative presentation. I want to ask, you said that according to NICE guidelines, the diabetes mellitus plus hypertension patients should be monitored for postural drop. Is there any recommended frequency, or is it at the diagnosis, or how to monitor it? The frequency?
They have not given a frequency there. And if the patients are symptomatic, we can monitor it frequently. And if they are not symptomatic, we can monitor it yearly.
Okay, got it. Thank you.
Dr. Kaushaya, Hasara here. Thank you very much for that really wonderful presentation. That was very nicely done. I have one question. So you said that this patient presented with vertigo initially, and then you got the differentials for both vertigo and dizziness. Is there a reason that you took for both? Because
No,
what did the patient exactly say to you?
no, that's those are the DDs for I wanted to include in the presentation actually. The
All
true
right.
differentials should be limited than that.
Yeah.
The list was very vast, and I just want to emphasize the things which you should
To consider in both vertigo and dizziness, no?
yeah.
Okay. Other than that,
Vertigo was excluded. In the history also, we excluded the
excluded.
vertigo part. This is pseudo
Yeah.
vertigo.
Right. Okay. Thank you. Just
Sorry
one
if I
more thing.
made a confusion.
No, that's fine. Just one more thing. This patient was on glycoside, wasn't she?
Yeah.
Was there any hypoglycemic episodes which could have contributed to this condition?
Could be, but her fasting blood sugar was in normal range throughout. And
Okay.
For this patient, hypoglycemic events, we couldn't get it from her clinic books.
Okay.
Always it was in little bit higher side, normal and little bit higher side.
Normal and high.
Yeah.
Okay. Okay.
For
Thank you.
this patient particularly, she had a history of atherosclerosis disease. She has undergone 2 PCIs in past 5 years, and she has a family history of atherosclerosis disease. And we actually didn't come to a solid diagnosis. It could be due to vertebrobasilar insufficiency even, or even there are contributory things in this patient, but as primary care physicians, we could manage without come to a diagnosis. We manage the patient at the primary care level.
Sorry, Dr. Kaushalya, one more thing. I noticed that she was on dual antiplatelets as well. Is it, was the PCI done recently or?
Yeah, recently done.
Okay. Thank you.
Yes, anyway, Kaushal is a very good presentation. You of course studied a lot as well as you read a lot to do this kind of presentation. It's good. Anyway, when it comes to the management plan, you talk about non-pharmacological and the mainly is that we cannot say so not only just a symptomatic management, but it's according to the cause, right? So non-neurogenic or because it's sort of a patient, if it is due to because dehydration, then we can do a sort of very non-specific symptomatic management. But there are, other than that, we have to find out exact cause for this thing and try to sort of sort it out the way the person had happened the problem. So because of that, we cannot say it's a symptomatic only. The cause matters. The cause.
We ask the patient to come review again if the
No, not this patient, of course, yes, okay, fine. Because it's a person, is a very neglected patient and with 2 PCIs and he had developed vomiting, diarrhea, he's very dehydrated and very pretty obvious difference in this, like this pretty obvious orthostatic hypotension when we examine. So that is something. Yes, I'm talking about the other patients, right? So there are like, could you please like concise this and tell us all the crowd audience. So how do you categorize like how the vertigo or the the way you describe without detailing each and every part? So how do you, in a nutshell, how do you classify these things? It's easy for them to like remember then as a take-home message, right?
Yeah, the vertigo, actually the dizziness, we can classify it as vertigo and pseudo-vertigo. And as I said, as we all know, the true vertigo, which the patient may describe of spinning sensation, and the mainly go by the history, and that true vertigo, as we know, it can be.
No, much I want to know the orthostatic, because you talk about that. The very that is of course otherwise it's a huge thing to talk about. We cannot say in a nutshell. It's a huge story. Only the thing that you're according to the discussion.
Postural hypotension, it could be neurogenic. There could be neurogenic causes and non-neurogenic causes. And neurogenic causes, as I said, there may be degenerative causes and neuropathic causes, and may be related to aging. And non-neurogenic causes, there may be most common cause would be dehydration. Dehydration may be due to hemorrhage or simply negligence, as you said, maybe due to hyperglycemia causing dehydration. And apart from that, there may be causes like drugs, especially like drugs like prazosin, which has the first dose hypotension, and the diuretics. And there may be other causes.
No, I mean, Kaushal is like this. Now you nicely described everything, in the presentation. So, like is non-neurogenic or the neurogenic, and then what are mainly the circulatory part, the non-neurogenic, the neuron part is the neurogenic ones, and then any specific symptoms according to the cause. There may be like 1 or 2 cardinal symptoms.
Yeah.
So, that is the thing we should then nicely as like sort of when a patient comes as a checklist, the people can just take 1 or 2. This is how we have to classify. Then it's very easy to get the causes. That's what I told.
Yeah. If the patient is having orthostatic hypotension, in that instant, we have to check the pulse rate increase also. We should check the pulse rate and BP simultaneously. And it is a rough guide. If the blood pressure, if the pulse rate increases more than 15 beats per minute, it indicates there is no neurological deficiency in that patient. If the heart rates don't rises up to 15, that means there may be deficiency in the neurogenic pathway. That is a one cardinal feature. And this could be a little variation with the patient who are in beta blockers and things. They may not have this rise in.
I tell you, now what you have to do is you better go through the thing and make a sort of a chart or whatever so how do you do this in a ladder, how do you do like that? So this kind of a kind of a guide is very important. Otherwise, in each and every section, like what you use the charts, even the emergency department, we use those flow charts, right? So likewise, better do then you can give the thing for all the colleagues.
Okay.
So then how do you differentiate and what are the cardinal symptoms in each of this section, like the flow chart? Can you do that for all the rest of the people? And then because then it's where the exams is very close by. If you can do that and share with them, it's very nice. I will give just 48 hours to you to do that job, right?
Okay, thank you, madam. I will do it.
Okay, right. Anyways, but you did a nice presentation. It's it's a huge thing. But you don't have to go for any very minor things. But I mean, when you see a patient, what are the main things you have to take? And then you can get all the possible causes. That is something else. But mainly, how do you differentiate one from the other? That is the most important thing, right?
Okay, madam.
Okay, right. Any questions for the people who are studying for the exam at the moment? If not, so anyway, now it's 11:15, I suppose. Yeah. Yeah, so we'll find out. Anyway, thank you very much.
Thank you very much, madam, for your guidance, and it will be it would have been a great pleasure to work with you. And thank you so much, madam.
Okay, thank you very much for your nice presentation as well.
Thank you, Dr. Kaushaya, for that very interesting and informative presentation. With that, I think we can wrap up for today. So we hope to see you again in another 2 weeks' time with another presentation. Good night, everyone.
Thank you, Dr. Helliker. Thank you, Dr. Prabha.